but it's great to be here. I'd like to thank Stan in particular for the invitation. I think it's good for both organisations to have the crosstalk of a meeting like this. Just my disclosures of interest. I've, over the last few years, received funding from Janssen Australia and Sanofi, and this is a list of the funding that I received for my research. I thought it would be important just to focus, why do we talk about bipolar? Because it's important for these reasons. And this was, to me, a very striking quote. If anyone has not read this book, I think it's a good read. Kay Jamieson, very highly regarded academic from Johns Hopkins, who went public 10 or 15 years ago with her struggle with bipolar, and a very moving autobiography of Robert Lowell, who was probably most people in the audience never heard of him. He was a very famous poet in the late 40s, early 50s, won the Pulitzer Prize in poetry, had severe bipolar, many admissions to hospital. And it was this quote early in the book that struck me. This disease of the brain bears down on all the things that make us human, our moods, the way we see and experience the world, the way we think, our changing capacities of energy and will and imagination, our desires, the gift to create, our determination to live or die, our expectation of the future, our sanity. And this is why this session is so important. You know, how can we improve treatment? What do we know about this condition? So I'm going to be focusing on longitudinal, long-term aspects of the illness. As well as being a researcher, I'm an active clinician, and the more I've been helping people with bipolar, the more I'm struck by the fact that in many ways the hard yards are stopping the progression, stopping the trajectory of relapse with this illness. So I'm going to focus on that. There's been an international growth of interest around the longitudinal or long-term aspects. There's been an international consortium set up called the Global Bipolar Cohort, initiated through Melvin McInnes in Michigan, and Michael and I are on that international grouping. So they published almost like a manifesto statement a few years ago about the importance of longitudinal research. So what am I going to talk about today? I'm going to initially look at clinical progression with the illness, the pattern of the illness over time. I'm going to focus largely on depression because that's really the main difficulty for most people with bipolar a long time. Make some comments about comorbidities. I want to also talk about biological progression because there's been increasing evidence about brain changes over time, early and as the illness progresses. I want to make some comments about maintenance treatments because I'm aware that we've got a mix in the audience. A lot of people with lived experience will be interested in treatments, and also clinicians and researchers, and just a few final points about maybe future directions. So let's look at some of the clinical issues. A few quotes from Lowell. I like Lowell, and I think just captures a lot of the illness. We feel the machine slipping from our hand as if someone else was steering. My bipolar can be stable, but suddenly I realize I'm sliding into a depression or a manic episode. The whole business has been very bruising, and it's fierce facing the pain I have caused, and humiliating to think that it's all happened before and that control and self-knowledge come so slowly, if at all. So someone as bright and capable as Lowell struggled with acceptance and understanding of his condition. What's the pattern of the illness over time? I came across a very good study. There's a very capable young psychiatrist researcher at Johns Hopkins called Fernando Goes. And Fernando looked at a big data set, some of you might have heard of, but the STEP-BD data set. It was a big multi-site US study that looked at people with bipolar over time. And he went back and looked at that data set. And what he was focusing on was the issue we're going to be looking at today. What's the long-term clinical pattern? And what he found, and I've got highlighted in yellow, we'll look at some graphics in a minute, that depressive symptoms predominated over time. Most people had trajectories characterized by various degrees of depression, and 13%, that's more than 10%, had a poor outcome, persistently depressed trajectory. And certainly this resonates with my clinical experience. I see a lot of people referred with complex, hard to treat bipolar, and depression is really the name of the game for most people. Most subjects experience few manic symptoms. So you might be surprised by that, but in fact, our treatments are much better for mania than they are for depression in bipolar. Obviously, people get mania long-term, but it's not the main game. 10% of subjects had persistent manic symptoms. We do see that. It's, I think, probably a bit less common than that in my own experience. And they looked at how function correlated with the symptoms. So let's look at a graphic from that. And I want you to focus on the right-hand side there, the one where you probably can't read, it's a bit small print, psychosocial functioning. The higher the line, the worse the functioning. And you can see that the highest line is the sort of greeny blue line, which is persistent depression. The next is mixed symptoms. So it's some degree of depression is leading to the functioning difficulties of people with bipolar when you look over time. So it's not just esoteric having symptoms, it's having an impact on how well you can do things in your life that you want to be doing. That international grouping has started to bring together data sets from around the world, and this was the first paper that looked at drawing together data sets and looked at what are the predictors of functional impairment or disability in people with bipolar around the world. And if you look again in the yellow highlighted area, the first statement is that poor levels of functioning were high. Okay, I think a lot of people outside bipolar area think most people with bipolar function fine all of the time or most of the time, but for many people, it's hard to do the things people want to be doing. And the biggest correlation or association was with depressive symptoms. In 10 of the 12 data sets around the world, depression was the strongest correlation. So again, the same finding, different methodology to Fernando at Johns Hopkins. Functional difficulties are high with bipolar, and depression is the major contributor. Not saying there's not others, but depression is the main contributor. Clearly, the tragic end of depression is suicide. And I'm not going to go into detail, but just to highlight that if you look at, for an individual, we're not looking at contribution to whole population because bipolar is clearly much less common than unipolar depression, but per head, it's the strongest predictor of suicide. And suicide is the tragedy with bipolar. A lot of my research in bipolar has focused on depression. So I want to make a few comments because some of the work that we've been publishing is now being sort of recognized by the field. It's interesting, when I first presented this, there was a doyen of the field who came up to me after a symposium and said, "Phil, you're going in the wrong direction. Depression in bipolar is no different to unipolar depression." I knew that he was wrong, but he was a respected statesman, so I sort of politely discussed it with him. But as the field has progressed, I think there's a recognition that there are differences in the likelihood of symptoms. And we published a review paper a few years ago that we called a probabilistic approach. And that means there's difference in the probability or likelihood of some features when people with bipolar are depressed compared to unipolar. Not that it's a different disorder, but there's a different likelihood of some of the features. So what are those? The first few are what we call atypical features of depression. Most people with unipolar depression have trouble sleeping, sleep less, eat less. But what we see with bipolar is that people often sleep more. And when you start to ask people, they say, I sleep 12, 14, even up to 18 hours a day. Not a medication effect. That was my first belief. But when you disentangle it, this is the illness itself. They eat more, often gain weight. People comfort eat often when they're depressed and then feel worse because they're putting on weight. They're often slowed down rather than agitated. There may be psychotic features, and there's often this mixture, this sort of hybrid mixed with manic features. Starts earlier, more episodes as well, and often a strong family history. And others have, and we'll look at some of our findings and findings from other groups around the world. We've looked at a few data sets through our Sydney recruited groups with both families with bipolar, but also big clinical, tertiary clinic data sets. And this is one of our studies published in American Journal a number of years ago, looking at people within the families. And what we found was that we looked at people with bipolar 1, where there's manic episodes, bipolar 2, just hypomanic episodes, and compared them to major depression. You might know that as unipolar depression. And what we found was people with bipolar 1, when they were depressed, compared to people with unipolar depression, were more likely to be slowed down and psychotic. More likely to be slowed down and psychotic. People with bipolar 2 were more likely to have mixed features, where you get this interplay of, usually hypomanic and depressive features. And when we looked at that probability list and we added those together, there were clear differences between bipolar 1 and unipolar depression and bipolar 2. So the message there is there are differences in the presentation of depression in bipolar. You always worry, I think any good researcher will question their own data. Is this some artifact or sort of chance finding in my data set? So when started to see very similar findings appearing from around the world, you start to feel there is a genuineness, and you're starting to pick out some of the biology. Some Chinese researchers looked at multiple sites across China of depression in people that turned out to have bipolar compared to unipolar. And the findings are very similar. So you can see, and this is a completely different ethnic group. These are Han Chinese people. Bipolar 1 was characterized by more atypical features, increased appetite, increased sleep, more psychotic features, more episodes, earlier age of onset. Bipolar 2 in their study had more psychosis. So very similar findings. You always expect little differences between different data sets, but this struck me in a completely different ethnic group. The findings are very similar. Fernando Goes, who I referred to before, looked at one of the big US data sets through their big genetics initiative, and he found in this American sample very similar findings. That people with bipolar 1 at the top there had more delusions, psychomotor slowing, functional impairment, mixed features, more episodes, shorter length, and also more likely to go high. Again, not exactly the same, but a really marked and impressive overlap amongst these data sets. So it struck me that this is picking up a reality of bipolar depression from around the world. I just want to make a brief mention of comorbidities, that bipolar has a very high rate of concurrent anxiety disorders. These are some papers published in recent times. I was involved in the second one of these. These are driven by a group from Canada. And we know that anxiety in bipolar correlates with poor outcome. Roughly 50% of people with bipolar have at least one anxiety disorder, and the more anxiety you have, the worse the outcome. Substance use similarly, and I'm not going to refer much more to this, but I think this speaks to the importance of how do we deal with anxiety and substance use in bipolar. I think most clinical services, most academics struggle with how do you do this well. So I think that's a challenge for the field. I just want to refer briefly to a study that I've been doing over a number of years, looking at young kids with a family history of bipolar. Some of you may be aware of that. There may be even people in the room that are involved as participants in the study. So it came from a question that had nagged me as a clinician and an academic. Can we pick up bipolar early? Can we do something analogous to what the schizophrenia field has done with early presentations? Bit easier with schizophrenia because there's often a prodrome. We don't have a clear prodrome. So how can we pick up bipolar early? What are the early features? I think pictures are often incredibly powerful. With this picture, Jamie in the middle has severe bipolar 1. His brother had suicided shortly before this, so very aware of the impact of bipolar. The two women to the left and right are his daughters, and Jamie has been very worried. Will his daughters get the illness? If so, will the impact be as severe as they've experienced, Jamie and his brother? So we've been doing this bipolar kids and SIBS study for a number of years. I won't go into detail, but just to pick out some of the issues relevant to what we're thinking about today. So the first issue is, and I just put that up because I think that captures why we do this work. Can we stop this illness progressing, or at the least reduce the impact of the illness on young people? So that one of the graphic artists at Black Dog at the time came up with this image, catch them before they fall. And I would imagine that the schizophrenia folk in the audience would also, that would resonate. That how do we stop this illness developing into a markedly impairing condition? The first one was when we first met people, what conditions had they had before? And in the yellow there, it's got affective disorder. That really means depression. So they've had depression before. That didn't surprise us. In our study, we got people before they developed bipolar, allowed other conditions. So they'd been depressed, but also there were high rates of anxiety disorders. And this is a finding that's been found around the world, that people at risk to bipolar have high rates of anxiety disorders before bipolar develops. We've now been following people up for 13 years. We're at the final stages of that. About 8% have gone on to develop bipolar. It's about what you'd expect for bipolar over time. Most of the big data sets that have just looked at clinical change have found roughly 8 to 10% over time. Number of developed subthreshold bipolar, new depression, anxiety disorders. So it strikes you very much that people at risk of bipolar are prone to a range of disorders, bipolar, anxiety, and depression. My interest has become more and more on the long-term pattern of the illness. And one of the questions we looked at with our early experience, this was in the first 2 years of the study, is could we predict who goes on to develop mania or hypomania? We looked at depression, and there were two questions we looked at. One, what was the nature of the depression in the kids with bipolar before they ever developed bipolar? So the kids of parents with bipolar, and then could any of this predict who would develop mania? Two things we found, that the depression even before they developed bipolar looked exactly the same as that depression that I spoke about before, sleeping more, eating more, slowed down. So it looks as though that's a characteristic of the illness even before people develop mania. The second issue was that depression, and particularly where they had these features, increased the likelihood of people developing a manic or hypomanic episode. So if we look at this slide, and some of you might have seen survival analyses before, the bigger the drop, the more the strength or the worse the condition. And what we found was the more of those features they had, the greater the likelihood of developing mania or hypomania. So I think there's something about those features that sort of is picking up some of the core aspects of bipolar. So those same features are there. They, at least in our data set, predict onset of mania or hypomania. I want to now move to look at biological progression. I think we've all sort of thought almost that the brain is unchanging as the illness develops. But what we're seeing are subtle changes in the brain. In schizophrenia, I'm aware that's been a clear and solid finding over a number of years. It's taken a while in bipolar because I think the findings are a bit more subtle, but important to be aware of this. Our group is part of the bipolar working group of a large international consortium called Enigma. It's nothing to do with decoding machines. It's a sort of or coding machines. It's sort of it's a clever wording. But this has allowed for large data sets. And what one of the first findings that came out of that bipolar grouping was if you look at people with established bipolar, there's a thinning of the cortex. It's not the same as in Alzheimer's by any means. It's probably less than you see in schizophrenia, but it's happening. And you see here, the more red or orange the colouring, the more intense the thinning. These are people on average in around their 40s. So that was a cross-sectional study. The same grouping published, and we were part of these papers, looking at change over time. And what did that find? Well, the thinning didn't come up as clearly, but we'll come to that in the next slide. There was an interesting finding about the cortical thinning, the surface of the brain. What was clear cut was that the fluid cavities, the ventricles in the brain, were enlarging with time, indicating some degree of atrophy centrally happening in the brain. In terms of the thinning, what was found was that you were more likely to have thinning in some parts of the cortex the more episodes of mania or hypomania you've had. And to me, that was a very striking finding. People have been wondering, are episodes of mania toxic on the brain? And this would suggest there is an impact, a cumulative impact of multiple episodes. And again, these highlight to me the importance of preventing episodes, of controlling the illness well. So we're seeing there's clinical progression, there's biological progression. And that's happening even early on. In our kids and SIB studies, we've had a big focus on neuroimaging, and we work closely with a very bright psychiatrist, imaging expert up in Newcastle, Michael Breakspear. Some of you might be familiar with Michael. We've identified networks in the brain that aren't as strong as in control subjects. And these largely involve areas of the brain involved in emotional and thinking control. And this was when we first met people, but we asked the question, does this change over time? We published a paper that appeared in the American Journal of Psychiatry last year. And there was this very similar network that was weakening relative to the same age people without bipolar or without a bipolar family history. What does that mean? Is it just an esoteric, interesting finding? What it's telling me is the brain is changing even before bipolar develops. So that there is a progression that's happening before the first manic or hypomanic episode. One of the analyses we did in the paper was look at, is this greater in people that went on to develop mania or hypomania? We didn't have enough subjects to have a strong statistical confidence, but certainly it looked as though this was more profound in people that went on to develop mania or hypomania. To me, this emphasizes the importance of early treatment. that there are changes happening if you've got a family history very early on. It's not just when you get into your 40s or 50s. I want to make a few comments about treatment because people will be interested in that for various reasons around the room. For those of you interested, I've just written a chapter on that in an American textbook, Tasman Psychiatry. If anyone wants a copy, just email me and I'm happy to send that to you. So it's an area I've thought a lot about. Just to comment that while lithium is an old drug, it's still our best for preventing mania. As the evidence has accumulated over time, that evidence has strengthened. It also helps depression to some extent, but it's not strong. The latest meta-analyses show there is an effect, but it's certainly not as robust as our effect on mania. So this sort of is talking to the story. Our treatments are better for mania in the acute and the preventive situation, but we struggle with treatments for depression. And I want to make some comments about depression, but first just a comment. A recent paper people would be interested in. The worry with lithium is kidney effects. A big study from northern Sweden that I think was very helpful. And what that study showed, if we look at the next slide, the first few columns, and this is comparing against a control population. Our kidney function deteriorates as we get older anyway, whether we've got bipolar or not. And what this shows is that for many years, it's no different when you're on lithium to the general population. But when you've been on lithium more than 10 years, that's when the impact starts. It was interesting, none of the people in this group had severe kidney effect enough to need a transplant or dialysis. But I think what this highlights is that if you're on lithium or a clinician prescribing lithium, it's at that 10-year period or more that you need to focus the whole time, but that's really the crux time. And I've seen this clinically. It's people with long-term lithium that you need to watch this. The editorial was very balanced and it reflected my approach. I like lithium. I think it's incredibly effective, but we just need to be careful that we're not doing significant damage to people's kidneys. Lithium's been of interest because of suicide prevention. It's becoming a complicated story because there's recent evidence from very large US data set that didn't find any effect on suicide prevention. So I don't think it's as clear-cut a story as we thought it was a few years ago. Let's make a few comments about treatment of depression in bipolar. And there were two quite important papers published in the last few months that really want to bring to your attention. The first was in Lancet Psychiatry, and this was led by Stefan Leucht, who's very good meta-analysis researcher published in schizophrenia field as well as in bipolar. And if you look at the section down the bottom, the conclusions or interpretation. So I think this is important because it's the biggest. I thought it was actually the most thorough in terms of the methodology. And they found that, and this is acute treatment. The next next paper we're going to look at is long-term treatment. But what they found was it was largely the atypical antipsychotics where there was the strongest evidence. I think a word of caution or a caveat, when they looked at individual drugs, the antipsychotics came out stronger. I think it's because other drugs like the antidepressants have never been studied by big drug companies, and so the numbers are much smaller. When they looked at classes of medications in their secondary analysis, they also found antidepressants to be effective. So I think that's encouraging for both clinicians and consumers that the antidepressants, in fact, there is good evidence as well as the evidence for the antipsychotics. I think the problem with a lot of the antipsychotics is the adverse effects. So it becomes a balance between the two. The role of antidepressants has been contentious. I've been to conferences, particularly in the US, where leading academic figures almost implied it was negligent practice to prescribe an antidepressant for someone with bipolar. I think the field has become more balanced in recent years. This was a big international task force. Michael and I were on this paper, which looked at what is the role of antidepressants in bipolar. And the conclusion was that as long as you're on a mood stabilizer, it's appropriate and safe to be using an antidepressant. So I think there's a better balance occurring. There was a very large Scandinavian study that they just accessed these amazing data sets at a national level. And that study found they looked at people with bipolar who are antidepressant and whether they're on a mood stabilizer. And if you're on an antidepressant and a mood stabilizer, you were no more likely to have manic episodes than people who weren't on an antidepressant. So I think the people should have a level of ease. I mean, clearly, we've all seen, the clinicians have all seen people go manic on antidepressants, and probably a number of the consumers in the room may have experienced that as well. So I'm not saying that happens, but it doesn't happen as commonly as perhaps the field thought about a decade ago. This is a paper published just in the last month, and an important paper. So the first author is Lakshmi Yatham. Lakshmi is a very highly respected figure in the bipolar field based in Vancouver in Canada. And he asked an important question that has been tricky for clinicians. So if you've got a person with bipolar, they're depressed, you get them better with an antidepressant, should you keep the antidepressant going or should you stop it pretty quickly? 5 minutes, good. So what they did was they randomized people with bipolar who got better with an antidepressant, and they were randomized to 2 months of antidepressant or randomized to a year of antidepressants. What they found, because there's two issues here, do the antidepressants reduce further depressive episodes? Do antidepressants increase the likelihood of mania? So two issues. It's a tricky paper to work your way through because they had to stop it during COVID because of COVID and funding problems. But I think there's two take-home messages. One, if you use sort of the hard-nosed statistical methods, there's no difference in the number of depressive episodes or manic episodes, whether or not you continue antidepressants. I think sometimes signals can come from what we call secondary analyses that aren't the primary. And what the secondary analysis showed is if you were on the antidepressant for the year, you had less depressive episodes than if you were on it for the 8-week period. So I think there's a signal, but it's not a strong signal. I think the other issue is it doesn't make you more likely to develop mania, which has been an anxiety in the field. What are clinicians doing around the world? It's an important finding from the US, a colleague, Andy Nierenberg. And if you look at mood stabilizers, that's lithium, epilim, tegretol in the red, over 15, 20 years, there's been a big drop-off in the US. And there's been a switch to antipsychotics in the blue. So there's been a major shift in practice, moving away from probably what we use more commonly in Australia, but you can see these same trends in Australian practice. That international grouping looked at experience from different countries around the world. And what did it find? Well, it found very similar to that. Lithium is used much less in North America than it is in Australia and a number of the other countries involved in that grouping. I think in the US, there's a recognition they're not prescribing enough lithium. They've overdone the push away from lithium. The other main finding was when they looked at antidepressants, Australia stood out as prescribing more antidepressants. And is that good? Is that bad? I think I would personally feel that there's a place for antidepressants. Is the amount of prescribing too much or too little? I think that's open for debate, but there are differences around the world in practice. Psychological therapies are important. I don't want to minimize that. I've focused on medications. The best treatment for bipolar incorporates good psychology as well as medications. I just want to finish off with just a few slides. What are some of the directions for the future that may impinge over the next few decades? I've given up sort of really crystal ball gazing. I wrote an article in the late 80s saying that genetics would impinge upon practice within a decade. And I sort of rue making that comment, but I still think that these will be important. We're now starting to understand the genetics much better. This was a paper that our group was involved in, Nature Genetics, a few years ago, that 64 genetic areas linked to bipolar. Very tough statistically to get a significant finding. You have to divide by 1 million because there's 1 million different markers. The next analysis is currently being done with a bigger data set. And just finishing, we need to do better how to manage comorbidities like anxiety if we're really going to help people. And I think the last point is we need to be thinking about early intervention. I think there's 2 levels of early intervention. One is when the illness develops, how do you stop it progressing? And the other question is, how do you intervene even before the illness develops to reduce the chance of illness occurring? There's numbers thinking about it. Greg Murray, who a number in the audience would be familiar with from Swinburne. Greg's been looking at this. Our personal discussion with Greg is, can we look at developing ways of intervening before illness develops? So I think early intervention, you'll hear more about bipolar, whether it's existing illness or very early on. I think I'll finish at that point.